Welcome, everyone, to the Transformation Nurse Academy podcast. This is our weekly episode, Talk with Kevin, where we cover topics for all nursing fields with extra emphasis on emergency and critical nursing. Get ready for candid discussions that explore the vast landscape of nursing and beyond.
Good morning, everybody. I appreciate you guys joining us. This is the Transformation Nurse Academy podcast. I'd like to welcome Matt Reavill and then Fitzgerald Samuel. Matt Reavill is from Reavill Med, and then Fitzgerald is from Samuel Medical, but you're working with Reavill Med now too. So I appreciate you guys coming on. If you can, just introduce yourself a little bit, Matt first, and then Fitzgerald, and tell everybody about us and how do we meet and what's your story?
Sure. I'm Matt Reavill, and I'm a former R&D engineer for BD. I've worked in the industry now for coming up on about 35 years. So I've been mostly designing medical infusion equipment, mostly syringes and needles and catheters. And then I got into medical device sales, where I started talking to nurses and learning more about our products. And somewhere along the way in there, my father died of a central line infection. And then it took a personal shot to me because I was one of the people designing these things. So my father died. I named the company Reavill Med after my father, not for me inventing this, but from my father's death from, what should have been designed to save him. And actually technically did for a while.
So if I can ask, how old was your father when he passed away?
59. He spent his 60th birthday. Well, he's technically 60. He got his 60th birthday in a coma and
that's crazy, man.
All the cars never got opened. He passed, 22 days later of sepsis, and that pain's still right there.
Yeah,
and
I can imagine, because I'm 55. I'm only a few years away from how old he was and stuff, so I can imagine that.
Unfortunately, stay out of a hospital. It's the same thing that we're doing now. So it's that hasn't changed. The only thing's changed is this.
Right. And then how about you, Fitzgerald? Tell us about you. I read your story, but tell everybody, introduce yourself and talk about you, where you came from and how you got with Matt.
Yeah, I'm Fitzgerald, and I was introduced to Matt around 2007. I was looking for information regarding a IV securement device that I was working on, and I was introduced to him by a lady over the internet. And maybe after about 3 months of working on that other device, the relationships kind of turned sour between the old partners, and Matt extended to me the opportunity of Reavill Med.
Yeah, that's good. Yeah, I was reading your story about that. I like that. I don't want to talk too much if you don't want me to about it. Are you okay?
That's fine. Oh yeah, please. Yeah.
You wrote in there that it was a certain person. She was working as an RN. She got stuck with an HIV needle and stuff. And we still, even today, we have high needle stick injuries and stuff. So I wish you would have got to produce your device, because this is something that still today is a big issue. And even with safety devices, I don't know how we can mess up safety devices, but maybe we need more education with nurses. I don't know. That's good.
Yeah, she is a friend of, or the mother of a friend of my wife. And we were over
today?
Well, yeah, still today, but she has passed now.
Oh.
Joan has passed now. She had a pretty decent long life. She survived maybe about 30 years or so.
Did she wind up getting HIV from the needle stick?
Yes, yeah.
That's rough, man.
Yeah. And we were sitting around at a birthday dinner one evening talking about inventions and all kinds of stuff. And her ex-husband, he had devised this little securing mechanism that would use a Velcro system instead of the adhesive tape, because the adhesive tape was just wreaking havoc on her skin. It was pretty cool. It was my first introduction into like the medical world and devices and infusion, and it's super interesting and intriguing. I love learning about it, and kind of just snowballed into all kinds of stuff. And I think like the full circle that it made is that so many roads lead to that sepsis at the end of the day.
Right, that's right. All right, so before we get into content, I have to ask, because I already know that all these women are going to be asking, where's your accent from?
I'm from South Africa, Johannesburg, or close by Johannesburg.
Because I already know they're gonna. People, women love that accent. Oh my God, Fitzgerald. All right, so not that you don't have a beautiful accent, man, but he got us beat hands down and stuff.
I can't. My Southern boy accent just can't compete.
Right. I know that's true. All right, so I have a lot of questions. I know that you guys answered them already, but could you briefly explain how both of you, we already talked about how you both got into the healthcare field, but how have advances in fusion therapy changed patient outcomes in recent years? We'll start with you, Matt.
Well, recent changes.
Yeah.
Yeah, I guess the biggest thing I'll say is now we're finally starting to trust the peripheral IV. The initial IV that you're getting, they're letting it do more now. I just saw an article on chemotherapy that let you do that with, but we still haven't resolved the fact that the peripheral IV is only good for about a day.
Why is it that it's only good for a day?
Usually they don't trust the person that put it in before them. The vein gives out and it clogs in that order.
I already know these answers, but do you know why an IV only lasts a day? Do you know what it is that we as nurses are doing or not doing that's causing it to only last 24 hours?
For instance, I'll take a personal story because those always work. My daughter was in the hospital about 6 or 8 months ago, and she was in there for only within the first 24 hours, she had 5 IV starts. I'm not going to throw research or numbers at you. I'm just going to tell you what I saw. 5 clogged IV catheters due to antibiotics. The antibiotic just not wanting to be in, the KVO not done. And this is the funniest thing. They talk about missed attempts. Not one missed attempt. They know they weren't using ultrasound and they were veteran nurses. They'd start the IV on first attempt, but it would not last.
But do you think it's because they weren't flushing it before and after, or were they flushing before?
Well, I was there the whole time. Nobody's got a better set of critical eyes on it than I didn't see doing one thing wrong. I just saw. Then I started taking pictures, and then I lost patience and told them to put in a PICC line. And here was my rules. Their rules. They said 4 failed attempts, right? You get a PICC line. Well, wait a minute. If a catheter doesn't survive this therapy, it is a failed attempt.
Right.
I don't care whether you missed the vein or not. It did not survive the therapy. Failed attempt, failed attempt, failed attempt, failed attempt. PICC line, you know.
Did they fight you on it?
Yeah. Oh, yeah, because that's not a failed.
Was this at nighttime or daytime?
Both. It went
because a lot of facilities don't use PICC nurses at nighttime. They only do it Monday through Friday, 8 a.m. to 5 a.m., 5 p.m.
I was ready for that too, because they said, well, you know, it's a Friday. The team is getting ready to leave. You only got about 2 hours to get them down here. I'm like, okay, we'll get them down here. And then I'm not sure. So I actually knew one of the mobile access teams, and I called her up and I said, hey, come on in and put a PICC line in. You know, just get up here and put one in. And I'm standing with my device ready too. I could have done one myself, you know. But I'm like, I'm actually paying my competitor to come in and put in a PICC line just so my daughter will quit getting stuck.
It's crazy though, right?
Yeah, sorry for a long answer on that.
No. It's a common. No, I want people to know because it's a common thing in the ED. We get nurses who, even though we're experts, they may stick 2 or 3 times. And
I want to tie Fitzgerald's story into that a little bit too. Those needles you're trying to get rid of are all those attempts. Failed attempts, missed attempts, those are where those needles are coming from and what Philippa Sharps contain.
Can you see my whiteboard?
Okay.
So I got your device up there so everybody can see it. So when you're describing it and you're explaining, everybody can see it. Hopefully it's recording.
Off to the left there, that's at Ava. That's my daughter right there next to Fitzgerald.
Oh, this is the one that had the multiple attempts.
Yeah, she got stuck 5 times in 24 hours. I'm only laughing because she just came out of phlebotomy training where they spent learning needle sticks on each other. Her arms were shot before she even went into the hospital. So you turned over to the professionals and they're doing their job, but the catheters just weren't holding up. I'll skip a little bit forward. That green cap you see in the rest of those pictures is a direct result of her stay. I can't prevent those clogs, but we can clear them and flush in another.
Right.
I made the clog actually hold the line. The clogged catheter is the KVO.
So what is the purpose of this green? How do you declog the line with this green cap?
You pull that green cap and the long line comes out.
Oh, I got you. Okay. So after you insert your device, you'd pull that out and it comes out.
Yeah. If
you can put a new one back in.
Yeah, exactly.
I got you. All right. Oh, that's cool.
So yeah, it's perpetual clog prevention. It can't occlude because the peripheral IV's always got something in it already. A catheter, another catheter.
How about you, Fitzgerald? Have you seen any kind of advances, or from the time you began with Matt, any advances in the infusion therapy field since you've been starting this project?
Oh yeah, for sure. There were a couple of big changes. I think one of them was the CMS stopping the payment for hospital-acquired infections. that created a big drive for keeping everything clean. Now that they're not getting reimbursed for it anymore, hospitals were trying to do whatever they can to prevent the infection. So, securement devices, the sterile maximum barrier protocol, and then also a reduction, because within that was the reporting of all the infections, and also sepsis numbers had to get reported. So kind of like the treatment was also a little bit managed, as far as like the use of central lines maybe got reduced a little bit, and there was a little bit more focus on a midline, since those infections don't get reported the same way necessarily. And they're also not as dangerous, so the further you can move away from that central line in the neck and the chest and do more work in the arm area, they become a little bit less dangerous.
So why do you think we've had so much? I'm just talking from my perspective because I've known Matt maybe 5+ years. We've
Yeah.
kind of known each other. Why have we had such a hard time getting his product into the facilities? Why is there so much resistance? Because I worked in the ED now for almost 15+ years just in the ED, and our doctors have they don't really want to put in central lines. And we were always told that you can't infuse certain things through peripheral lines. And so, why do you think there's such a pushback on this device? Why don't they accept it?
Fitzgerald is the reason we are where we are. Our device has gone through 6 modifications, major modifications. And I'll give Fitzgerald probably credit for about all of them. He'd say, this is the way we need to do it. This is what's wrong. And then finally it got down to where it is now. So that's number one, product revision. But number two, the market moved to that peripheral IV. Yeah, I understand in the ED they don't like central lines, but if 1/3 of peripheral IVs are going to fail, that's not exactly a respite.
Right.
So we needed a way to go to the peripheral IVs and to fix it. So that's where we are now. So now we've got a bullseye. We've got the right product at the right time to where the market is. And we've got that price down too. So that you're talking about $5 to make an IV catheter go a year.
Not just that, but and I'll talk about that because I made a highlight about your dwell time and stuff. But the sepsis bundle, unless it's changed and I'm having a senior moment, it said that you should have a central line in to start monitoring CVP and infusing.
They did CVP. It was designed that you weren't supposed to over infuse, but they got rid of that, and now they just really more important to get those antibiotics and fluids
That's
in.
right.
I agree to that to a point, but if the fluids are going to cause kidney damage,
Talk about that too, because that's one of my pet peeves in the ED, man.
yeah. I got to admit,
crazy.
Here's the good thing is my only dog in this fight is, I've got the way to do it on one needle. So whatever you're going to do, let's not keep resticking the patient and increase venous depletion. I can get them around the central line. I can get them one IV that'll do it all, and then it doesn't need replaced.
Well, kind of talk about since you brought that up. Kind of talk about that. Talk about, because a lot of nurses don't even know what a midline is. I know what a midline is because I've been in fusion therapy for a while. But what is a midline, and your product kind of fits into that? I know that you say you're not a midline, because I read your notes here. I don't want to steal your notes, but you said we don't call ourselves a midline because of the dwell time a year. What do you call it?
And I kind of make it a midline is a middle range catheter, and it can be used for a lot of things. Its popularity is growing exponentially. The problem with the classification of midlines, according to the FDA, they have to be pulled at 29 days. You can't go any longer than that. And that's not our category. That's FOZ, FDA clearance. Ours is LJS. We're catheters minimum 30 days. So we have to go at least 30 days, or there's something wrong with the device.
So can we call your device something special, like create a whole new category?
Yeah, you can call it a vascular access.
Yeah, but everything's a vascular access that enters the vein. But I want to give it a Fitzgerald. You got to work on this. We need a fancy name to come up with. Because we have PICC lines, midlines, peripherals. We need to come up with a fancy name, man.
He did. He came up with a good one. What is it, Fitzgerald?
Oh my God, we'll call it the back and forth.
No, the one and done.
Oh, the one and done.
Oh, the one and
done.
Because remember, the midline catheter is inserted here somewhere in this area, typically in the basilic, but it can be in this area here, right? 6 to 8 inches long.
Correct.
Right. And the tip of it usually goes right before the axillary space. But where does yours end up at? Where does the your device go?
Well, we're going to be 17 centimeters deeper than where you put us in.
17 centimeters. I got to write this
Yeah.
down.
So wherever,
17 centimeters wherever you insert.
yeah. So wherever you put in, our dispensing distal end is going to be 17 centimeters deep in that vein. So it's
17 centimeters is about maybe, calm down over there, Fitzgerald. I know we're not on the metric system in America, but I'll get there. 17 centimeters is roughly about 6 to 8 inches, 8 to 10 inches.
yeah, that's where there's the catheter inside your 6-inch extension set. And then when you connect the two, this is what I do all day long on Zooms, by the way. This is what we did at Ava. We just show that you can extend the length.
I like that though. That's craziness. I love it.
Yeah. So now
is that as long as it will go? Is that as long as the device is right there?
it goes as long as the extension set. Whatever extension set you buy, if you buy a 20 centimeter, 60 centimeter extension, the catheter is going to be that long too. So 6-inch extension, 6-inch catheter. Now there's your midline question. If you put in here where you normally do for midline, it's going to be midline length.
So when you're talking about the extension sets, there's like 4 inches, 6 inches, 8 inches, 12 inches. So that device fits inside of it, and that's how long it's going to go out.
Correct.
Oh, so you have different. Oh, that's nice. I like that.
Yeah, so that's kind of what I want to get to with you real quick. So if you put us in a midline location, yeah, for what you know and what you think is a midline, great. But you'd have to pull those at 29 days. Us, you leave in.
Right.
You go past 29 days. And so that's what.
So the device, you're inserting your device to my IV that I created. So what size IV do I need to insert for you to use your device?
20 gauge or larger.
20 gauge or larger. So does my device come out?
No. You have to use my peripheral IV because it's guaranteed a 1-year dwell.
That's what I mean. So if we use our device in our facility, it wouldn't work because those are only meant for 24 to 40. I mean, it would work, but it only lasts for 24 to 72 hours, ever how long our policy says we got to DC it.
I'm sure the FDA is going to watch this one, so I'm going to say this answer very carefully.
I got you.
You could perform what you're talking about with any peripheral IV over 20 gauge or larger. All right.
We can't leave it in there more than.
Well, you've used it off label. You've already taken it off label. So
I got you. Okay, I got you.
Use it all, but if
so we're technically required to use your peripheral IV if we're going to use your device.
If you're
to keep it in there longer than 29 days.
Right, and the reason is I'm responsible for it.
I got you.
I'm responsible for that to go at least 30 days.
I got
you. Can't be responsible for anybody else's product.
I got
just the one I provide you. Now, that being said, what do you need in your kit? If you're using a B-Bron needle, a BD needle in your kit from Reavill Med, there it is. You just can't grab one off the shelf. It's got to come in my package, and I've got to be responsible for its process through the hospital. So just
does your IV catheter, your peripheral IV catheter, is it come with the needle, just like a regular device?
Yes.
I'm just using your. I got you. All right.
Go back to the whiteboard. I'll tell you where we're using an Anexiva.
And that's what Fitzgerald helped you design, right? And kind of tweak and.
Oh yeah.
Let me see. Can you see it, Fitzgerald? Can you see my board?
Yeah, I can see the whiteboard. Yeah.
That's a 20 gauge Anexiva.
Yeah. I'm not. Just so you know, I'm not a big fan of that device.
Well, it's common in hospitals. Let's put it that way. And it's the technology, and when you say what the hospital's currently using, there's a good chance it's that.
I know.
My only problem with it is it's just not long enough. The catheter's just not long enough to dwell in the vein for long periods of time. And this resolved that problem.
My issue with it was when you try to insert it, it sticks, and it's so hard to get those two pieces to separate. And I think that movement alone can cause you to damage the vein because you're trying to separate the two pieces. People got to understand they got to break the seal first before they use it.
Yeah, to each their own on which one they use.
My device is the one that probably designed way back with the other company.
Oh, yeah. Okay. The hardest, for Reavill Med, 97% of the battle is getting into a vein, quality vein. If you've done that, then we can hold it. It's just I'm required to provide you the peripheral IV and responsible for its characteristics.
Do you
specifically the past 29 days?
Do you prefer us to use ultrasound machine when we're inserting our IVs? Would it make a difference? Does it make a difference?
Oh yeah, same as a PICC line. If you're going for the long dwell, you've got to find a quality vein. And the sooner you find a quality vein, the quicker you can quit using all the others. Venous depletion comes from all things you do outside of the one IV that's working. So if you've got one IV that works and lasts a year, go for the good vein, put it in and leave it in. Take care of it.
Right,
Maintain.
because we're changing IVs every 2 or 3 days sometimes, if not more, because patients bend their arms or their veins are fragile or the
So
nurses
yeah,
are inexperienced in sticking IVs.
that's kind of one of the little notes I gave you about this meeting is that I agree with the vascular access industry and AVA. I just think it's on the wrong end of the hospital.
So explain what you're talking about.
The sepsis bundle, all 5 steps are vascular access, all of them. So it's got to be done in an hour.
So talk
And
about the 5 steps real quick. What are the 5 steps for the bundle?
the first is measuring lactate. The second is volume resuscitation. The third is broad spectrum antibiotics. Fourth is vasopressors, or that may be 5. And the other was continuous monitoring. I don't have the bundle in front of me.
No,
It's
that's
5
good. That's
steps.
good. That's good. Yeah. Go ahead.
The only
Go ahead.
thing is the CVP isn't necessarily in there anymore, but you have to do a blood draw before you start your broad spectrum antibiotics.
Right, because we got to do
Step
our
2.
we have to draw our blood cultures.
Yeah.
Yeah, you have
Right.
to before you administer the antibiotic, or you'll ruin your test.
Yeah.
So your device is a 1 French. Is that what I understand?
1.7.
So is that going to cause any hemolysis when I draw blood through it?
Not at all.
Because nurse will worry about that because 1 French seems small compared to what size is a 20 gauge IV?
So there's a product on the market from BD called Pivo.
Yes.
It's got a smaller ID than we do.
Right.
We're bigger than that thing. So if Pivo can do it, then obviously we can.
Right. To me, I think a lot of times it boils down to the technique of the nurse, the size syringe they're using, and
Yeah.
what they're
Well,
doing.
and
Right?
vacuum container tubes pull too hard. Remember, you're talking to a BD engineer. So yeah,
Well, I didn't want to say anything because I didn't want to get you in trouble by mentioning that. But since you mentioned it, I'm not going to be afraid to mention it because I do use BD products because they're the biggest around, and you probably design most of the stuff that we use today. Yeah.
they're a great company, and they'll adapt to what's coming. They just didn't get there quick enough with this area.
Right.
So BD is a great company. Whatever you need in your kit from BD, you can get in Reavill Med.
So talk about that because this is one of my big passions about, since we're talking about sepsis and the five steps of the bundle, you made a note in here about overhydration and acute kidney injuries. Talk about that because a lot of nurses think I'm crazy when I talk about sometimes we give too much fluids because we don't monitor correctly and we don't know how to monitor as nurses.
Yeah, you can't. You can't just start. The kidneys have shut off for a reason, or they're fragile. Just throwing a bunch of fluids in just is going to ask them to work harder.
Right.
So you have to be subtle here. Patient's your kidneys will come back on if you live long enough. That's kind of with that infection rule. So don't burn them out.
Well, I'm following this nurse. Her name's Stephanie, and she works for one of the competitors of BD, but she's been doing a lot of research. She's more of a critical care nurse, but she's been doing a lot of research, and they're showing that we're giving 5 to 7 liters too much in the ED.
Oh yeah. So that fluid it's actually called a fluid challenge, and the reason they're doing that is they're testing to see if you can make urine. You put fluids in, and if your kidneys are working, you'll make urine. It's just a real quick test of organ failure. And kidneys are going to be the first organ to fail. So that starts the what do they call it? The cascade of organ failure starts with kidneys. Right. So the first test you have is, are they working? And so you put some fluids in, and the patient should start producing urine. If they're not, then you need to quickly not do fluids anymore and move to vasopressors or something else.
Right.
And vasopressors can burn the kidneys too. So that's a fast, good way to make a kidney fail is overuse of vasopressors.
They can also burn veins if you don't infuse them correctly as well.
Correct. Yeah, but that's kind of points I bring up about dialysis. 1/3 to 1/2 of dialysis patients, or kidney failure, come from sepsis.
Right.
Whether you get the sepsis or was it the treatment of the sepsis, but the way 1/2 to 1/3 are walking away with acute kidney injury.
So how does your device help us with that? How can we try to get this into the EDs and use it effectively to treat our patients and prevent those kind of injuries?
So that's 2 parts to that. The first off is time. You can get in and do what you got to do and do everything on one needle. That just speeds everything up. We call that the golden hour. To get those infusions in, you can power infuse through us. You can get everything through on one needle, and you can do it with You can start the antibiotics, leave them in long, all that done on one needle. Blood draws, all that. You just get started sooner.
So on the screen, I probably missed it, but on the screen, I only have the single lumen, but I know that you have more than one lumen. If I'm
Correct.
not mistaken, you can make it a double lumen or a triple lumen. What can we use?
Double lumen, double staggered lumen.
And what does that mean?
Okay, you actually do have a picture of it up there on your above the. This time it's done with a 14 gauge over there.
Is to the right, top right?
Nope, to the left.
This one here.
There. All right, now look at that. That's not a 20 gauge that I'm using there.
No, that's like a 14 gauge.
That's 14 gauge. Okay,
you trying to kill me.
Well, now if you need fluids, that's a pretty good size.
I know it is. That's right.
If you're trying to get 3 liters of fluid in an hour, that thing right there can do that in 7 minutes.
Right.
Move your cursor off to a little bit to the right. Okay, well, that's fine. All right, so that's dual lumen. There is the distal lumen way to the left. So that long catheter, that is the distal end of the green hub. Okay, same device. The green cap is dispensing at the green arrow. Distal lumen.
I got you. Okay. So if I connect the maintenance IV solution right here, it's going to come out down here.
I prefer you put the antibiotic there.
Okay. So antibiotic goes there.
Or the vasopressor.
Or the vasopressor. So what?
Yeah, put anything that's got to go deep and can't infiltrate, you want to put through here. Now, the fluids, go back to where that needleless connector is. Change the color of that to orange.
Where am I putting it at?
Into that 14 gauge.
Right here.
See where it ends? Right there. That's it. All right, now go back to the needle-free connector all the way on the right. Correct. Flip it upside down if you can. Perfect. There you go. All right, so that's your dual lumen. Now, most importantly, that's called a staggered dual lumen. They are not dispensing in the same area of the vein. There's typically a valve between that orange and that green arrow.
I got you.
So that way you can infuse through the green while you draw blood through the orange or hydration or whatever.
But your device is going through the lumen of the orange catheter.
Correct.
If I draw blood, if I was to connect here and draw blood,
yes,
because your device is going through the lumen, is it going to cause hemolysis or any issues when I draw back?
No, you're going around the long catheter. You're going through you're getting that from the. I got
you, but it's basically going through like this, right? I mean, as I'm drawing back through it, is it going to cause any problems? You know what I mean? If I'm drawing back blood through it?
No, in fact, you're going to get better results because it's a large bore peripheral and that long catheter within is giving it a kite tail, meaning that it's going to stay in the middle of the vein and not pull up against the vein and fall.
All right. Okay, try
In dialysis, they call that a dead eye.
Say that one more time.
In dialysis, that's called a dead eye.
A dead eye, all right.
Something that holds the intake, the arterial end inside the vein.
I never knew that. See, I've never worked dialysis. So
now I bring that up because right there, that device you're looking at, the reason I used a 14 gauge, there's your dialysis catheter. That'll go 350 milliliters per minute.
All right, that's nice.
So you could
use it for multiple things.
Yeah, exactly.
So if we were to talk to some nephrologists, because I have a connection with nephrology groups,
yeah,
that'd be something they may be interested in.
Yeah, it's a godsend. For one, you don't need a fistula.
Oh, all right.
You don't need a dialysis catheter out of the neck. You just need 2 of these. This one you do need 2 of because you got to have an arterial and a venous, but at 350 milliliters per minute.
I don't want to put you on the spot, but is this going to be better for the fistula long-term wise? Like for the
Well, yeah, because this has got a 1 year, actually technically a 3-year dwell.
Right, but I mean, just talking about my personal experience, fistulas sometimes don't last very long. They clot off, so they got to go and get another one. Would this one last better? It has better results?
A fistula's got a 6 month to a year timeout before you can even access a fistula. So you're given a central line dialysis catheter.
Right, of the temporary port and stuff. I got you.
Right. And that's in your neck. And you have to wear that for 6 months till your fistula is healed, and then you can use the fistula. So I'm saying in the ED right now, you can get started with 2 of these. Now there's that 14 gauge. Don't get me wrong. It's got to be some size on that peripheral, but that's your intake.
Gotcha. But I mean, that can be put in under ultrasound with a little sedation or maybe some lidocaine or numbing agent.
Yeah, it's a lot less painful than the dialysis catheter.
Yeah. And it's going to last longer and has better results.
Yeah,
And that's now,
exactly.
is this what Fitzgerald's been helping you redesign and make it more efficient? That what
No,
he's
that one he didn't help with. That one's early, so
all right.
he's helped me with all the other stuff. But but he is an expert on dialysis too. We've batted that one around before. So yeah, it's this one I haven't worked with him that much. So let's say there's probably some improvement coming from Fitzgerald that I just haven't talked to him about yet.
That's nice. Though. I like this. See, now I'm gonna have to start talking to all my nephrology contacts for it because I
Well,
got a boatload of those and stuff. So
if I have kidney failure and I can get out of 2 surgeries, yes, please.
yeah, because it's very painful, and going through that graft and stuff is traumatizing sometimes, and sometimes they fail for whatever reason. So
Mhm. So I think just having 2 of these around in a dialysis center is a must have, because the moment that fistula fails, what are you going to do?
right,
Patients still need dialysis. So
I
it's
like
just
this.
having this handy to get started to see, even if you just want to see if it works, go ahead.
Yeah, I like
Does
this.
it pull, and if you're really in a mist about it, just pull us out and leave the 14 gauge in and use it, and then flush another one of us in when you want to keep that 14 gauge patent.
So if somebody wants to contact you or Fitzgerald about how to get this device and how to get it into their facility and start using it, I have up here on my whiteboard your revelmed.com, but is there any other way you want me to have them contact you?
Really, that's fine. You can info at revelmed.com is the general email.
All right. So don't forget that Jane info at revelmed.com.
Yeah. And then you can either get hold of you or Fitzgerald too.
Yeah.
Just
All right.
send up there,
Yeah.
you want
So Matt's
else,
on Matt's on LinkedIn, Fitzgerald's on LinkedIn.
yeah.
Yeah. Is there anything else that I missed that you want to talk about, Fitzgerald, or Matt? Anything I missed that you want to discuss about your product, or anything that's on your mind that you want to share to people that's listening?
Yeah, I kind of want to just briefly touch on the sepsis and the sepsis protocol again, kind of going back to the early 2000s when Dr. Rivers came out with the sepsis bundle for the emergency department. He basically took what they were doing in the ICU, and he was saying that, these patients, 2 out of 3 of the sepsis patients that they see come through the ED.
Right.
And so he's like, let's bring this protocol down to the ED so we can catch these patients earlier. And, for obvious reasons, putting a central line down in the ED is a little bit more cumbersome than doing it in the ICU. So the central line became a big hurdle for them. And that CVP got probably the most criticism because for the most part, you can do a lot of this stuff without the central line except for the CVP. And so what kind of stuck with me is the fact that the therapy was already started long before the CVP was starting to was being measured. So when you look at a therapy and you want to compare what it looked like before you started the therapy versus, and then compare it to what you were doing afterwards, CVP was kind of in a gray area because you had to justify, the patient had to get sick enough, the lactate level had to reach a certain point before
Right.
they said, okay, now we have to put a central line in.
Right. That's right.
And so, like, that number was always, you didn't really get the full picture. And so, with the Reavill Med device, you reduce a lot of that risk, you make the procedure easier, it doesn't take as much time. So there's an opportunity to possibly measure the CVP even before you start the fluid.
Right.
So like, and then you talk about what is the outcome going to look like there. And, with this device, it's really difficult to not think about that aspect, considering all the complications of what's keeping a traditional central line from being able to be used that way.
So I want you to think about this. I want you to think about this, though, Fitzgerald, what you're talking about, the CVP central lines. Our biggest weakness in the ED is most ED nurses have no critical care training, but yet we're responsible to take care of critical care patients. I was a trauma ICU nurse, but I'm now ED nurse, and I can see that a lot of nurses in the ED don't know how to set up a CVP or never have set up a CVP. The doctors don't want to put in a central line because it either takes too much time or they don't get reimbursed for it. I mean, just talking from my experience. So that's why I want to find your product a way to bridge the gap so that we have no more excuses.
Yeah, and then on the other side, it's just like I was saying, it kind of jumps back and forth because you really have the benefit of a short peripheral IV when you think about the insertion of the device, right? So it starts off small, you have the benefit of that. There's less exposed material to the environment when you're inserting all that goodies. And then you go to a midline and you can use that midline to extend the distance between the actual access site versus the dispensing site, for extravasation to kind of help and prevent that. And then, especially with that 14 gauge, the orange one on the screen, if you pulled that 6-inch extension out and you were able to put maybe like a 3 French through there, now you have the possibility of measuring CVP.
So if I took that device out that's in what's on the screen, you can reinsert a longer device in there and push it all the way to where we need to measure the CVP.
Yeah, so that it can
We don't
escalate.
have to DC the original device. Is that what you're saying?
Yeah, you do it from a pick instead of from the neck.
Say that one more time, Matt.
You've made a pick.
I got you. Okay. All right.
Yeah, so you leave that peripheral in place, and yeah, you can advance and just escalate from that point on.
Right.
So you don't have to
The other option,
you don't have to do a whole new procedure, is what you're saying.
Correct. Yeah, you swap out a short one for a long one. You take one,
right.
50 centimeters, 55 centimeters, whatever length you need to get to the superior vena cava, and that'll measure your central venous pressure from the arm instead of from the neck.
That's nice.
And then the other thing is that even if you use the 6-inch extension and you placed a access device in the IJ, then it becomes a central line automatically.
This is a central line.
Right. So, because a lot of EDs like I work in, as long as you get the proper training, you have the competency, I can insert an IV into the EJ. Does it have to be EJ or does it have to be an IJ?
Both.
If I do an EJ for the doc, he or she could put in this device and basically turn it into a central line for us.
Yeah, it is a central line.
Yeah.
Once a cat reach that superior vena cava, it is a central line.
That's nice. I like that. All right, it's good.
Well, that's where we were for a long time, but central venous pressure kind of fell out of favor with the sepsis.
Right.
So they don't measure it anymore, or at least turned away from it. But so be it. We'll stay 17 centimeters.
So all you ED docs and ED nurses out there, you have no more excuse now that we can put in these devices. They're cost effective. They're effective for the patient. So no more excuses.
Yeah, there's a rad little doohickey. It's like this little portable CVP monitor. And they're pretty nifty if you just wanted to get a quick baseline, instead of having to hook it up to all kinds of monitors. And
if you can, send me a picture and link that, because I don't think I've ever seen that.
It's called the Encompass device. It's available from Medline.
Encompass. I don't know if we have that.
It's they do. We don't. But yeah, if you need it, get one from them.
Maybe Reavill Med needs to work one on their own.
Well, there's certain battles we'll take on.
I know. I'm just trying to give Fitzgerald more work.
Oh, yeah. We'll beat that one around. So, yeah.
All right, you guys. Is there anything else that we?
By the way,
go ahead.
3 things real quick, and I better say her name before it. Fitzgerald wasn't the only one influential on this device. There's been quite a few, but if we don't say Nancy Moreau right away,
I just talked to Dr. Moreau yesterday and stuff. I love her. She helped me out because I
everybody and she's the one that said you got to make it smaller, you got to make it 20 gauge, and you got to make it a midline.
Yeah, that's good. Though,
and
she's a nice lady. She's friendly, even though she's a doctor. She's friendly. She talks to us. Love her. I love that lady. Yeah.
I do too. She's awesome. And then
Dr. Monroe.
Thank you. And then also I want to mention this is a godsend for neonates. This is those little guys and gals don't stand a chance with a whole bunch of needles and veins that don't work and bad technique for putting in long catheters. This is the way to do it in a closed system that's sterile.
So this is okay for neonates as well.
Oh yeah. We have a version in 26 gauge. I don't have any hospitals that have ordered that yet, but it is available. It's we're just getting started, but this is it's a 1 French catheter inside of a 26 gauge peripheral.
All right.
And now that one does not measure central venous pressure. It's just too small.
It's all right though. But for all you pediatric nurses out there, if you are having a hard time or you need something that you need a long dwell time for your neonatal patients, here it is. So
Yeah, and then
contact them and ask.
And then the Nexiva, if you use it with the Nexiva 18 gauge, obviously we have to supply that in the kit, but that's your dual lumen.
All right.
It's single lumen with the 20 gauge, but if you use and that's with the near port, not the regular Nexivas that are out there. You got to get the near port, the ones that work with Pivo. That's a biggie.
NEAR port.
Yeah, NEAR port.
Port. All right.
And
so
yeah,
so you're saying I have to use a Nexiva is what you're saying?
Yeah, for dual lumen, you got to use an 18 inch. Or I don't think they make a 16, but
no, but you're saying I have to use the Nexiva is what you're saying.
No, there's other. If you're using Nexiva, I'm saying just go up a size. A 20 gauge dual lumen, you got to go to 18, so that I have that coaxial gap.
Okay. So are there other devices I can use to make it a dual lumen besides the Nexiva?
Bebron's got one. ICU Medical's got one, and we have a T connector that works on those to give you the dual lumen. So we can make anything dual lumen as long as it's larger than a 20 gauge.
And I don't want you to stretch both of you out, but is there a way you can give me a small list of a few of those devices that I can put on the notes and stuff, on our Facebook page, so that way people can look at and research and look.
Yeah. The only reason I'm saying that, it's the needle you're using. You want to use whatever needle the hospital uses.
Right.
And we'll kit it out so that they're dual lumen. Okay. If that makes sense. But instead of showing you every needle that's out there, you just have to work with us and let us kit it for you, and then we'll make them dual lumen. Reavill Med dual lumen.
All right. Perfect. Is there anything else we missed?
Two more. Sorry. We're getting a lot of buy-in from hospitals that have gotten rid of their phlebotomist.
Oh yeah, there are a lot of phlebotomists that's because here in California, they're wanting to pay every healthcare worker $25 an hour, and I know the hospitals aren't going to do that. So
well, that pushes blood draws to the RNs who are doing it from peripheral IVs, and that green cap on the Reavill Med device is a godsend. It'll prevent the catheter from clogging.
Okay.
So it's going to accomplish the Pivo effect, except you're just going to leave it in. Not like Pivo, you got to put a new one in each time. This you just leave in long and draw from it, and if should it ever clot off, you just pull it and flush in another.
Right, I got you. All right. You would take the device that's contained in the syringe, connect it to the green port, and flush it in?
Correct.
I mean, not to the green port, but to the device that we've inserted in and put in a new one?
Correct. The device goes into whatever you're using. Pull the old one and flush in a new one, and you're back in business.
That's good. And then the third thing you said, you had one more. So you said you want to give thanks to Nancy Monroe. You talked about the neonates, phlebotomists. I'm looking on your notes. We talked about the overhydration. We talked about the kidneys. We talked about the one and done, the sepsis bundle. We talked about your dad. Vascular access experts are doing everything right on the wrong end of the hospital.
Yeah. We need that expertise when the patient, if you're going to do a one needle hospital stay, you got to have the skill set to put in the first one.
Right.
And phlebotomy, I apologize that industry is leaving the hospital, but that's venous sabotage.
Right.
And every time they stick a vein, that's one less you get to use.
Right.
So I support moving the RNs to doing the phlebotomy, and this device makes that happen.
Right. I know. I mean, to me, it's all saves patients' veins, but it also saves the hospital money too. And patient satisfaction goes up.
Thank you. That's I guess probably the only other thing I had to say is, on behalf of Fitzgerald, on behalf of his wife, my wife, and my entire family, we hate needles.
Right. I think really,
we're not clinical, but we'll be your patients, and we just don't like being stuck.
All right. So one last thing before I let you go, think about plasma donor centers. You ever heard of those?
Red Cross, things like that.
Red Cross like that. I don't know if it would work, but just think about that. I don't know if it's going to lyse the cells or anything, but
the only reason you'd want to Reavill Med that is if you were a chronic donor, which I don't think those exist.
There's people that do it 50 times a year.
Yeah, that's probably worth a healthy. Let the vein heal and yeah.
Look, Fitzgerald, that's true. People do it 50 times a year, right?
Yeah.
Do they get paid for that or something?
Yes, they do. That's why they do
okay.
it. right, you guys. I really appreciate you coming here and taking the time. I really appreciate that because, it means a lot that you took your time out of your day. I know you guys are busy. So this will be posted probably in a week or two, but I'll make sure you guys get a copy of it. And Matt,
right.
I didn't do what? One time.
You didn't swear once.
Yeah, I love it.
Thank you.
So all you people know that Kevin can have a conversation without a foul mouth.
Just before we go real quick.
Yeah, go ahead, Fitzgerald.
All right, so just a couple of things that I've encountered when going to conferences and chatting with people is they would ask me about the valves.
Oh, yes.
Yes. And how it seems like it's an issue with the traditional over-the-wire exposed catheters when you bump up against the valves. With this one is that when it's infusing and you're putting pressure on the syringe, right? So you're basically injecting the catheter. When it hits a valve, there would be a momentarily like a pause. But if you just keep the pressure, as soon as that valve opens and there's that fluid moves through, this thing just goes and sails right in.
So you do know how to help people with that issue?
No.
So this is what I've learned by doing IV therapy for so long. When you take a deep breath in, your valves open. And when you take a deep breath out, when you blow out, your valves close. So right before you push, if you tell the patient to take a deep breath in, it increases that pressure in your body and it will open the valves up.
Oh,
you
okay.
Great.
You could see it when you're drawing blood and stuff. People are breathing. You'll see the blood stop. And then as they hold their breath, the blood will flow. It's crazy. So.
Whoa, all right, cool.
Yeah. Try it. If you have that problem, try it. You'll see what I'm talking about. It'll make a big difference. I don't know if there's a way, if you guys have ultrasounds and stuff and you can see the valves, maybe ask Dr. Monroe if she can get pictures of the ultrasound and specifically on the valve and watch people taking deep breaths in and you'll see that it'll make a big difference.
I think
that's great information.
That's great. It's it's actually just an easy technique to test even without ultrasound. Just breathe in so that or go forward. Yeah.
All right. All right,
Thank
you guys. I appreciate it. Yeah, I appreciate you guys. Yeah, I had a
Thanks,
good time.
Kevin.
This is going to be an awesome episode. Yeah. Nice to see you. Nice to meet you, Fitzgerald.
Yeah.
Thank you, Matt. Thanks for taking the time.
Thank you very much, guys.
Yeah. Thank you. Have a great day, man.
Cheers.
Yeah. Stay in touch.
Bye-bye.
Don't miss out. Engage with us weekly. Share your thoughts, and let's transform the nursing landscape together.